Hello, everyone, and welcome to the fourth season of McGill Cares webcast series supporting family and informal care partners. I'm Claire Webster, a former caregiver, certified dementia care consultant, and founder of McGill University's Dementia Education Program. I work with a dynamic team of leading healthcare professionals to oversee the program, who include Dr. José Moret from the Division of Geriatric Medicine and Dr. Serge Gauthier, Professor Emeritus, formerly of the McGill University Research Center for Studies in Aging. McGill Cares is supported by the Amelia Saputo Community Outreach for Dementia Care. I would like everyone to know that the McGill Dementia Education Program offers a very comprehensive range of free resources to educate and support persons living with dementia, family and informal care partners, healthcare professionals, medical students, and the public at large. One of our most important resources is the Dementia Companion Guide, which can be downloaded for free and is now available in over 10 different languages. So just go to mcgill.ca/dementia, click on the Dementia Companion Guide, and please begin reading. So we're kicking off the fourth season with a very important topic, which is a novel approach which exploring the experience of stress in formal and informal dementia care partners. And with me is one of our national leading experts in this field. My guest today is Dr. Zahinoor Ismail, a clinician scientist, and professor of psychiatry, neurology, epidemiology, and pathology at the Hotchkiss Brain Institute and O'Brien Institute for Public Health at the University of Calgary. He has a certification in behavioral neurology and neuropsychiatry and geriatric psychiatry, with over 20 years of clinical experience, and sees patients through cognitive neurology and in seniors' homes. Dr. Ismail is chair of the Canadian Conference on Dementia, chair of the Canadian Consensus Conference on the Diagnosis and Treatment of Dementia, which generates Canadian dementia guidelines, the most recent iteration of which were published in 2020. He was also recently appointed as co-chair of the Government of Canada's Ministerial Advisory Board in Dementia, for which I too am very proud to be a part of. Dr. Ismail has authored 250 peer-reviewed papers. He's the principal investigator of the nationwide Can Protect study, which is funded by Brain Canada, the Canadian Consortium on Neurodegeneration and Aging, the Canadian Institutes of Health Research, and Gordie Howe Cares. I'm so grateful to have such an expert with me as well as a colleague. So welcome to McGill Cares.
Thank you very much, Claire, and thanks for the wonderful introduction and the invitation to lead off the fourth season with a topic that's dear to us both, and that is caregiving and caring for persons with dementia. So thank you very much for having me. As Claire mentioned, we're going to talk about caregivers, and I want to discuss a novel approach to exploring the experience of stress in formal and informal dementia caregivers, how we are generating data to understand this better within the context of understanding what is dementia, what are the diseases that cause dementia, how does it affect the person with the disease and those who love them and care for them. So we will review contributors to stress in dementia caregivers by describing an overall framework for assessing stress, providing clinical examples of contributors to stress, and then reviewing some preliminary data from informal and informal Canadian caregivers that we have from the Can Protect study, which I'll describe shortly. As a bit of background, in clinic, sometimes family members and patients they don't always know the difference between Alzheimer's and dementia, or the terminology is vague to them. So the way I approach this is often I'll say, first of all, what do you know about dementia? And they might provide some sort of definition, and then I'll clarify it for them, and then move on. And usually what I say is something like, dementia is a clinical syndrome that's characterized by the insidious onset and gradual progression of cognitive changes, usually memory, and that is associated with functional impairment. And it's that functional impairment that then results in a diagnosis of dementia. Prior to that, it might be mild cognitive impairment, or it might be subjective cognitive decline, But it's the dependence on others to function that really is the hallmark of dementia. Now, there are diseases which cause that syndrome of dementia, and the most common disease is Alzheimer's disease, followed by vascular cognitive impairment and cerebrovascular disease. And there are rarer diseases. The next most common is probably Lewy body disease, which is associated with Parkinsonism. And this is what, for example, Robin Williams had. And then frontotemporal dementias and then different diseases that cause frontotemporal dementia. When we think about function, this little infographic I thought captured it nicely. We divide it into instrumental activities of daily living and then basic activities of daily living. And it's the instrumental activities of daily living that usually show some change first and happen earlier on in the course, whereas the basic activities of daily living, the hygiene, the bathing, the grooming, the toileting, the ambulation, those happen later on. But it's at that IADL impairment stage that there starts to be some impairment. Initially, it's subtle. People make more mistakes. They take longer. It might lead to some sort of conflict for various reasons that because of an undetected underlying disease. This impairment might be attributed to other things, and again, results in some stress or conflict. But then it becomes more apparent, and family members, if available, may take over some of these roles, and then that ultimately progresses to the extent that people are really fully dependent and functionally impaired. When it comes to Alzheimer's disease specifically, there is a National Institute of Aging and Alzheimer's Association in the US framework for it, which is a research definition and some clinical staging. And it acknowledges that one can be symptom-free and still have the underlying disease for many years, maybe 15 years, before symptoms start to emerge, and that we can classify that as preclinical or prodromal or formal dementia. And that while we have a cognocentric model of dementia, and we really think about memory and executive function, other cognitive domains, and the primacy of those symptoms. In fact, dementia is much more than that. And as mentioned, there is impairment in function, but there are also physical conditions in the living environment that affect how people function and perform. And then there are the behavioral and psychological symptoms, which are the depression or anxiety or changes in behavior and personality that go along with this progressing disease, which can actually emerge in 30% of people with Alzheimer's disease before cognitive symptoms. So the cognocentric model alone doesn't capture everyone, especially at the early stage. Now, we measure all of these things clinically. And for example, in the family doc's office, or certainly in the specialist office, you would get a Montreal Cognitive Assessment, for example, which is a screening tool. It's not for diagnosis specifically. It's a screening tool, and it might lead you to consider diagnoses once you work up other factors. But it probably is the most commonly used screening tool. I remember in 2005 when the MoCA was pretty new, we did a survey of family doctors and found that a handful of percentage of them were using the MoCA. And then when we did this a number of years later, it was by far and away the most commonly used tool. So it has legs and it's well known. Now, this is an objective test. We have a patient or a person with potential cognitive impairment in front of us, and we would administer this test and score it and ask it. But what is really underappreciated, and this is a fundamental issue in dementia care, is that we have to ask others who know this person if there are issues. So as Claire mentioned, I'm chair of the Canadian Conference on Dementia, which will be held in Toronto this November from the 2nd through the 4th. And one of the themes in the meeting is dementia in primary care. And an important part of that theme is engaging family members, caregivers, care partners, those who love and care for this person are with them to help with understanding them, to help make a diagnosis, to help get all the information that's relevant. And Unfortunately, in primary care, this is very hard, but it's absolutely necessary. And it's one of the major themes in the conference this coming year. So what we do in clinic and what I do when I see new consults in seniors' homes and senior and retirement residences is I also have a little package that I give to family members and caregivers. And if they're, for example, a new person to assisted living, then they would get, the family would get this ECOG, which compares them in a number of cognitive domains to how they were 10 years ago. And it tests memory and executive function and language. And it's a very helpful tool because it gets the family's perspective of how they are. And even visually, you can just look at it and see, hey, okay, these are the concerns. I better make sure I attend to those when I'm assessing the patient and when I'm administering the testing myself. I also have a package for those, for example, who are in a memory care unit and for whom I get a consult. Then I have a package for the staff, the personal care aides, the LPNs, the nurses, to provide other information. The ECOG for them is not as relevant because it compares their current function to how they were 10 years ago. Sorry. And this is where the family caregivers are so incredibly valuable and important. We also assess function, and that usually comes from the carer. And here are a couple scales. On the left, I think, comes from the Bristol ADL scale, and the right, the Functional Activities Questionnaire. We also use the AD8, which is quick 8 questions. A score above 2 might be consistent with dementia. There are various ways, but it's very important that we track and monitor function as much as we can, knowing that it's a proxy report, and we're often not doing objective measures of function unless there are safety issues or we get a home OT assessment, which are very, very valuable and gold because we don't get them as often as we'd like. As I mentioned, we have a cognocentric model, and the dementia diagnosis is triggered by function, but behavior is a large part of dementia. And when you have comorbid behavioral changes in dementia, it's not a good sign. So if you take two groups of people with cognitive impairment with dementia, and you divide them up based on whether or not they have neuropsychiatric symptoms or behavioral and psychological symptoms of dementia, the group that have the behavioral symptoms, they do worse. They have greater functional impairment. They have poorer quality of life. They're institutionalized earlier. There's a greater degree of caregiver burden. The overall economic costs are higher. They progress to severe dementia more quickly, and they have an accelerated mortality. So it's really imperative that we address and care for all aspects of dementia for the person with dementia and those who care for them. Here's a scale I use. It's adapted from the mild behavioral impairment checklist that I use for new consults in seniors' homes, for example, that captures behaviors in various domains like drive and motivation or apathy, or affective symptoms of mood and anxiety, or agitation or impulsivity, or loss of social graces, tact and connectivity, and then psychotic symptoms like starting to become suspicious or seeing things or having frank delusions. I'll focus a little bit just on agitation, one of those 5 domains, because it's underappreciated, often detected late and only when there's an emergency. And this is very hard on carers. The FDA once upon a time said they will not approve a drug for agitation until the field can actually define it well, because in the literature, agitation is ill-defined and people use agitation, aggression, and no one can really come up with a consistent diagnosis. The International Psychogeriatric addressed that issue in 2015, and then we revised the criteria this year, which were published and now formalized for an agitation definition that breaks it down into 3 domains: excessive motor activity, verbal aggression, and physical aggression. And what's important here is it highlights that agitation isn't just physical, that it can occur in other ways. And if we detect agitation earlier, we can address a potential stress for both the person with dementia and those who care for them. We can treat it more successfully with non-pharmacological treatments than we can physical aggression, where that works not as well. And if medications are required, we can use gentler medications than the big guns that are often required for physical aggression. So early detection is very helpful from many fronts, but it's not appreciated how common the verbal aggression stage. And what the data tells us is that for those who develop verbal aggression, they often can progress to physical aggression. So addressing this early is good from many fronts. Things to know about agitation is that we often consider agitation as something as episodic. They had an episode of agitation. Studies will ask us how many episodes of agitation have they had. But if someone is developing a style or tone or change in personality, such they have become more verbally aggressive, they resist against care, they're argumentative or rude, and this is just their changing way of interfacing with the world without any episodes of agitation. They are clearly having behavioral changes that are consistent with agitation. And sometimes caregivers are on eggshells. They do everything they can to try avoid an outburst, but they're suffering even more. And it's not addressed, it's not diagnosed, it's not treated. And it's an unmet need and a brewing issue that we often see. So it's really important that if, as the brain changes, we understand that people can have a shorter fuse and poorer frustration tolerance, a loss of their filter, rudeness or argumentativeness. And this does not reflect on them as a human, as a person, as who they are, or who they were. And I think that's really important. People might have stigma around putting a diagnosis to someone because it might color their impression of this person. And it's nothing like that. The diagnoses are to help us improve the quality of life, the function, the symptoms for everyone involved. And when someone develops changes associated with their brain disease, it has nothing to do with who they are and who they were. They remain that person. And everyone needs to be reminded that this is a disease and a syndrome that results in great hardship for some. Now, as we know, caregivers are underappreciated, under-recognized, overburdened, and there are resources. And as Claire mentioned, the Dementia Caregiver Guidebook or Handbook, which people should download from McGill. We have in other studies, for example, used this 36-hour day from our collaborators at Johns Hopkins. There are other resources, but what we know is that despite the interest and the focus, we know that we don't know enough about the experience of carers. And by carers, I mean not only the family and friend or informal caregivers that are unsung heroes in helping manage people with dementia, but also the paid care staff, whether it be a paid companion, the home care worker, the personal care aide in long-term care, the LPNs, the nurses, the physicians, the occupational therapists, the rec therapists, all of those involved in dementia care are also under stress and burden. And for them, we know very, very little. So with that in mind, we leveraged a study that I launched earlier this year called the Can Protect study. Now, Can Protect, it launched in March, and we have over 2,000 participants already. The idea behind Can Protect is it's a 20-year longitudinal study whereby we have formal validated neuropsychological testing. So you do on your computer or your tablet. And then there are actually brain training games that may help performance along those tests. And then a whole series of questionnaires on cognition, on function, on behavior, on quality of life, on demographics, on health status. Some are mandatory, some are voluntary. For example, childhood experiences, they're a voluntary one. There's a brain injury questionnaire that's a voluntary one. People tailor the study to meet their interests and their needs beyond the core battery. And as I mentioned, we have over 2,000 participants, and anyone over 40 really can join. And it's about a 5-hour commitment per year, not in one sitting, and then their annual visits. And as I said, we just launched in March and have generated really interesting data on those first 2,000 participants. And I believe we've submitted 9 abstracts based on these data to the Canadian Conference on Dementia in November, because it will be a very robust data set to understand brain aging for Canadians. Now, within which, and this part has been underappreciated and not promoted at all. So the next stage is to really promote the caregiver component of Can Protect. And there have been a number of rating scales developed specifically for caregivers, for care partners to understand their stress in a very organized fashion, to understand their role, understand their trajectory. And then it can be linked, and this is very unique in caregiver research, it can be linked to the objective neuropsychological testing that we have and the markers of quality of life and stress and mental health symptoms, and how those links are affected by their sex or their cultural expectations on becoming a caregiver or their role within the family, and their own health status, et cetera. And to give us a really robust, detailed look at the experience of persons who care for dementia. Now, we have some preliminary data, and I'll share that with you, from about 49 informal caregivers, and about 37 formal caregivers. And sorry, by informal caregivers, I've been using the term care partners for the family and friend caregivers, and caregivers for the paid. I know the terminology varies, and we'll try to be consistent with that. Even the field is not always consistent in how we describe persons who care, aside from the broader term of carers. Now, here is, for example, a snippet from one of the scales, and I developed this specifically because I was looking for nice, robust measures of assessing stress, and there are validated scales out there, but none of them met the needs that we had for the study and assessed caregiver stress in a detailed enough fashion to answer the questions that I had. So I developed this scale. It's got about 42 questions in it, and organized into domains such as stress related to the cognition and cognitive impairment in the person with dementia, into their behavioral change, into stress associated with their functional impairments. There are also questions regarding the caregiver. In that caregiving role, are there unmet needs, or what is the emotional impact on that caregiver? How does stress interfere with the work or vocation of the caregiver, and are there financial implications? How does that caregiving role fit into the context of other family members of the person with dementia? And what is the situational perception of the caregiver, and how does that affect their stress? And again, not only can we assess stress based on this 7-point Likert scale, but then we can link it both cross-sectionally and longitudinally over time to trajectories of health, wellness, cognition in this study. So that's why it's a really nice add-on to the ongoing brain aging study, because we can get all the brain aging measures with links specifically to caregiver experiences. Similarly, I developed a scale for caregivers, for professional caregivers, formal caregivers. There is nothing. I searched and I found 2 scales on stress in inpatient nurses, not dementia specific at all. So I had to go and develop this scale as well. And then I worked on it with staff that I worked at in the seniors' homes to make sure that it represented their experience, and these were valid questions. And so we have this scale with about 34 questions in these 5 domains. So are there factors associated with the patient or the resident, the person with dementia, that affects stress in various domains? Are there the family of origin, the family that, and the formal and the informal caregivers of this person? Are there stressors associated in the interface of the formal caregiver with the informal caregivers? Are there environment, workplace factors? Are there psychological, emotional factors, and then interpersonal and inter-team factors? There is a massive shortage of healthcare aides and personal care aides across the world, and certainly in Canada. And there's high turnover, and there's poor retention, and that has an impact on the caregivers, and there's a vicious cycle. So if you start on the right, fewer services and reduced provision of support result in more care responsibilities falling on care partners, a greater stress and burden, and a greater need for dementia services. The greater need for those dementia services results in a greater stress, burnout, and turnover in the formal caregivers. And there's results in poorer services, inconsistencies, which is a common complaint I hear about, is that's a new person every week, for example, say in home care. And then this results in a greater burden on the informal caregiver who's got lots going on anyway, and then is trying to patch up the holes because the formal services are not working. And then it goes round and round and round. And this is why I developed this study to assess both formal and informal caregivers, the whole care team. And that, like I said, everything from the paid companion through to all of the allied health professionals and nurses and nurse practitioners and physicians involved in the care, because we really need to know, where are the choke points? Why do more people not want to do this work? How can we make it more fulfilling? Are there areas that we can address and target for interventions at a personal level, at a system level, at a patient level, to get away from this vicious circle and improve quality of life for everyone involved? So here are some questions, for example, about from the informal caregiver scale, so the family and friends. And I mentioned the domains of cognition, behavior, function, unmet needs, work interference, family interference, and situational perception. And you can see some of those questions, and I won't go through them all, but all of these are based on my experience, I think 24 years of practice, encountering, caregiver difficulties and where they have struggled. And they're a very important part of what we do. When I see a new consult in the clinic, I always make sure I speak to the caregiver separately, and also make sure I ask how they're doing. And that happens in follow-up visits too, because sometimes nobody knows how much they're suffering. Sometimes people do, and that's happening more with greater awareness, but just not enough. So, for example, are they suffering with the cognitive changes in their loved one? The forgetfulness, such that they have to repeat themselves, or the person is losing items, or they're making, they collectively make decisions, and those conversations are completely forgotten, and then the caregiver is left in the lurch. Is it inattention? Is it difficulties in communication with language loss? Is it recognition of faces and places? Or is it around executive function decision making? In terms of behavior changes, we break it down into those domains that I talked about earlier, and with a further breakdown into the agitation symptoms, because I know from experience that those are underappreciated and not well measured. The functional impairment, is the stress associated with assisting with activities of daily living, like the bathing and the dressing and the transferring? And I've had patients who are big, burly men and small, frail wives who are trying to get them out of bed and on and off the toilet, and it's just terrible, and it causes a great burden. So we need to know these details. Is it managing the instrumental activities of daily living? If one spouse always did the finances and then they are no longer able to do it, and the spouse who's never done it before is now responsible for managing the household, that is a great burden, right? Is it going to medical appointments? Often a child will bring their parent to an appointment, and they're looking at their watch, or they're looking at their phone, and they take a call and they got to run out, and it's hard for them. They have their own kids, they have their own job, and driving wherever and finding parking in a hospital and all these miserable things to get the care that their loved one needs. That's a source of burden. What about legal issues? The notions of personal directives and power attorneys, which differ in every province. In Alberta, it's really weird in that a personal directive will cover everything but finances, and will also cover legal documents and contracts, which may have financial implications, but are covered under a different document and a different act. And caregivers are overwhelmed with finding this out at the very last minute, that no, they do not have the ability to prevent someone from making a very bad financial decision, or who got scammed by someone who got into their bank account and cleaned it out. We've seen it all, right? And this can be a great source of burden. It could be a volume issue. Are there just too many tasks? Okay, for mom today, I've got 19 things to do. And I also have to eat. Right? That's unpleasant. The amount of time. Or is it the person's loss of insight into their awareness? When I see people early on in the disease course, I'll ask, how's your memory? Well, it's not as good as it used to. Something's going on. At some point, they come back to clinic. How's your memory? Memory's just fine. Nothing wrong with it. Right? And they're much, much more impaired. That can be very distressing. Those unmet needs. Again, when you're giving full time, more than you have to someone else, where do you get to, how does your cup get filled? Do you have enough time for yourself or your interests? Are you able to do that? How is your social life? What about if you're a single mom and you're taking care of an aging parent with dementia? How do you meet other people when all you're doing is taking care of your kids, trying to pay the bills, and take care of your parent? Are you missing out? And do you feel guilty or inadequate for giving what you have, which may in some eyes be not enough? It's a horrible feeling. The work interference and financial strain, missing work or poor work quality due to caregiving obligations, absenteeism or even presenteeism because you're tired because you're up at night, financial hardship related to caregiving, and concerns of how to pay for those future caregiving needs. And again, there are big jurisdictional differences across the country. And this is why Can Protect actually is well suited, because it's a Canada-wide study. And we have representation from every province. What we need are more caregiver representatives from every province to tell us, how are the systems affecting stress? Are certain medicines covered or not? Is home care provided directly, or is it through an agency? Or is it all provincially covered? And do those differences affect the amount of care that you're able to get, or the quality of that care, or the appropriateness of that care for the person that you love if they don't speak English, and the home care staff that come through only speak English, or if there's a mismatch in culture or language? Does this result in adequate care? Are there ways around it, or does it result in greater burden falling on the family member? And of course, I mentioned financial exploitation and scams, and those can be devastating. In terms of family interference and interpersonal conflict, is there a detrimental effect of caregiving on your own personal relationships? Not enough having enough time for your family, conflict with your family and how to provide care. And I see that often amongst siblings, more often than I'd like. Or, the oldest daughter is the one who manages everything, and perhaps a son might take over the power of attorney when he's in town. I see that, and that's a very gross gender stereotype. But part of Can Protect is actually understanding the gender roles, the roles of sex, of gender, of culture, in better disentangling the contributors to stress. And again, these are all come out of my clinical experience. So I'm speaking to specific cases. Feeling underappreciated by family members for efforts in providing care. I had a lovely woman who had one daughter in town, another daughter in the US, and a son out west. And they were never satisfied with the care that she gave, and she gave everything she had. And when they came in, they felt like they needed to fix everything. And it didn't necessarily feel fair, right? Now, as much as I could understand from those dynamics, what we need to do is understand that better. And then the situational perception, right? Do people feel unable to control it? Like it's out of control? Do they not know enough? We try to provide as much education as we can. And for example, when I provide a dementia diagnosis at say an initial consult, I'll bring them back to do another education session. I don't want to squeeze it in there in the few minutes before the end of clinic. I give them websites and resources, Alzheimer's Society, locally, nationally, to look up. And I say, come back, bring your questions. This is what we're going to do. And then I also provide education on lifestyle and diet, on exercise, and all those other things as well. because families are interested in that. But it all depends on the amount of services and the availability of educational materials. Being unprepared for a new role or responsibility. I mentioned that before, managing the finances. What is your role? Is it a new role? Do you feel like you have a role? Do you feel like you have an identity? Has it been lost? Has it been taken? Do you feel stuck or trapped in this role? It's not the role that you want, but no one else is going to do it. And here's my parent. And what if you didn't have a good relationship with your parent? How does that even amplify or exacerbate these feelings of being stuck or trapped? And not seeing an end to it, and not having enough family support or professional support, which brings us then to the stress in the professional carers and professional caregivers. There are, and again, these all come from clinical experience and discussions with various staff I've worked with over the years. Are there physical demands to do impaired basic activities of living? I talked about the wife trying to get the burly husband out of bed. Similarly, is this person a 2 or 3 or 4 person transfer? Is it the cognitive impairment that results in the stress? Is it the behavioral symptoms like the apathy, mood, agitation, socially inappropriate behavior, including sexually inappropriate behavior? We do see sometimes people touching care staff inappropriately, which is distressing to all, right? And how about family factors? Is there a lack of understanding of the patients on behalf of the family of the disease and management? Sometimes there's a disconnect between the carers and what they think they can provide and expectations of family, who are either have been suffering and distressed, or maybe have been disconnected and not necessarily understanding what is the reality, especially if they're, say, coming from out of town or they haven't been involved as much. Are there different family perceptions of challenging behaviors, or, as I mentioned, unrealistic expectations? Is there conflict of disagreement between family members? How does that play out for the person who's trying to provide care? At all levels. Are staff approached with questions from family that they have no answers to? Do they feel helpless because of that? What about lack of respect or rudeness from family members? I've certainly seen that. And how does that affect someone's ability or desire to work in this profession? What about the environmental workplace factors? Is there a heavy workload? Well, that's a silly question, right? There is always a heavy workload. How are the hours? COVID told us how bad this can get because people couldn't then work, go between different homes, and they were stuck in one home. And there was no coverage, and so their hours became longer, and the workload heavier, and it was very, very hard for everyone involved, all around. Is there lack of backup from other healthcare professionals in your own profession, or in allied professions? And how does the team work? Is there lack of adequate training? Well, often this is the case. And how does that affect stress? Are there unrealistic demands from management or ownership? Is it a public healthcare model? Is it a private model? Who is calling the shots? Is there a living wage? Are there sufficient benefits? And if not, how does that affect the ability to give and care? The psychological, emotional factors of the caregivers. Is there internal conflict or guilt or helplessness, exhaustion and burnout? Witnessing people decline, the death of someone with whom you're attached. I feel this regularly. Witnessing the suffering and inadequate preparation to deal with the emotional needs of a patient or family, and embarrassment or shame, about someone's behavior, perhaps when you're on an outing, a group outing. Are there interpersonal factors like difference in caregiving approach or conflict amongst team members who are providing care? How does that then play out in terms of someone's job satisfaction, their willingness to care, to interface with the family caregivers, to do that extra, or to move on to something else? Are there language or cultural differences, which I alluded to earlier, between the caregiver and the patient? Is there, and I've seen this Is there a perception of racial prejudice from patient, family, or others? 90% of personal care aides in Canada are women of color. And how does that play out in terms of the workforce and respect from colleagues, from administration, from patients? The intersectionality of this job and appreciating it is very important if we want to recruit and retain healthcare workers who work with persons with dementia. Their perceptions of different levels of commitment or work ethic. These are team issues, right? Someone working harder than the other, is someone more confident than the other, or the perception of that. All of this contributes. So I'll show you some data. As I mentioned, we have only 49 family informal care, care partners, and 37, I think, formal ones. And we haven't promoted this at all. So this through McGill Cares is a great opportunity. We'll hear more and more about this over time, and I'll be seeking funding specifically to really amp up this to get to the target of 500 family caregivers, 500 professional formal caregivers across the country, of various ages, of various of males and females, of various gender identification, and across the ethno-cultural, ethno-racial diversity that is Canada, to really try to understand this situation better. So here are just some brief and preliminary data from the family caregivers. The mean age of our caregivers is about 62, but it ranges from 40 up to 80, I believe. Various degrees of education. And then here are just the stress on that Likert scale that I described earlier. And here are the scores classified by the cognitive, behavior, function, unmet needs, work interference, financial interference, and situational perception domains. And maybe I'll just discuss a few of them. And so some of these, and again, these are small numbers, and these are unsophisticated data at the moment because they are sheer mean scores. They are not adjusted for any of the covariates that we might consider important, like age, sex, gender, ethnocultural group, education, health status, mental health, all of those caregiver factors that can contribute to stress. None of those have been incorporated into this, and we will do that because those are nice, robust statistical models that we will build once we get large enough numbers to do that. You can't just run all of those covariates with a small number because then you just get imprecise estimates and errors. So you have to have a large sample to really be able to include those contributors. But just based on a sheer frequency of reporting, it was actually forgetfulness that was the highest contributor to stress with the highest mean score. And I didn't expect that, and who knows, that may be a robust finding, or with larger samples, it may become different, but that's what we have right now. Number two was item number 19, which is caregiving time based on functional impairment. And that actually makes a lot of stress. Spending a large amount of time managing the functional deficits that have evolved in the person with dementia can certainly be a contributor to stress. Third on the list was communication difficulties. And of course, I've seen this clinically, we all have. Trying to understand what we're being told, or trying to get our point across and give instructions to someone can break down. And when it does, you can imagine, and probably that it contributes to stress. Fourth on the list was item number 7, which were emotional symptoms. So these are the mood and anxiety symptoms in the person with dementia, whether it be worry, excessive worry, or sadness. And in my clinical experience, it's the worrying that can be infectious and results in stress more than the sadness. And then the number 5, and we'll probably stop at number 5, is decision making. Is item number 2. Inattention. So the inability to again, a cognitive domain, to focus, to attend, to listen, is associated with a high report of stress. Now, on to the formal caregivers, and again, only 37 of them, about similar age. So a lot of these are family caregivers. And now, one thing we will do in the next step of this study is we will drop that minimum age. Right now, the entrance into Can Protect is cut off at 40, but that actually precludes many care staff. Many of the staff I work with are under 40, and I want to know their experience beyond what they tell me. And so we'll very shortly drop the age just to 18, and it'll become just a study of brain aging in any Canadian 18 or over the next 20 years. But that will allow a larger representation of caregivers. And as mentioned, the domains were patient or resident factors, family factors, environmental workplace factors, psychological, emotional factors, and interpersonal. We'll just go through the top 5 again. And item 6 was the number 1, and this really caught me off guard. And it was apathy. So apathy, which I study, I have a trial in apathy. I write about it. We published a really nice paper on apathy in advance of dementia as an undetected factor that contributes to faster progression to dementia. And apathy is broken down into 3 domains, which is reduced interest, reduced initiative, and reduced emotional reactivity. So reduced interest is the not caring as much about things that you used to. Maybe you used to really like music, you don't anymore. Reduced initiative is the get up and go, has got up and went. People are less likely to get out of bed and less likely to want to get up off the couch. And then the 3rd domain is a reduction in emotional reactivity. So they become more meh, there's less expression in one way or the other, and they're more muted. And family members can feel disconnected from their loved one, and caregivers can feel disconnected from the people they care for if they're not potentially showing any interest or emotion in that whole caregiving experience. So that was the highest scored domain. I'm, again, quite surprised. Number 5, cognitive impairment. So that is consistent, with what we're seeing in family caregivers. And then the number 7, item 7 was the 3rd, and that's the mood and anxiety symptoms. And then number 27 was 4th on the list, which is exhaustion. So in the psychological and emotional factors, it's exhaustion in care staff that is, the 4th biggest contributor, or the 4th highest mean stress score, in this small sample of 37 people. And then item 4 is the physical demands, was 5th on the list, which, is intuitive and it really makes sense. But what we'll see as we get a larger sample and we can address those lower ones better, we'll be able to predict who will have stress based on their individual factors, and then address those earlier on in the course, and whether that's for a family caregiver who's just taking on this new role, or whether it's new staff in home care or in long-term care, or in other community agencies in a day program or hospital, and address those issues to ensure that then their work experience is better, so they stay and continue to care for our loved ones with dementia. The big question is, how do caregivers cope? And it can be in a myriad ways. There are myriad ways that this can happen, and people can get angry. Everyone's entitled to a meltdown on occasion. They can have anxiety. They can have stress. They can feel grief. And it's the mourning. It's the loss of identity. It's the loss of their own role. It's potentially the loss of their role as a caregiver once their loved one passes on. They wonder who they might be, and they might turn to alcohol or drugs, and develop mental health conditions of their own beyond symptoms like stress or anxiety. overall, again, leading to burnout, exhaustion, a loss of oneself. And it's a really big issue. We are starting to understand how to address it and how to manage it. There are resources, but we need to know more. And what we need to know more is at an individual level, based on really robust data. So we can say, okay, someone with your profile, these are your risks proactively. Let's make sure you do this and this and this, because we know from this large sample of Canadians that you are at risk for burnout, for stress, for taking sick leave off of your own work, or whatever the outcome may be. But there are resources, and as Claire mentioned, the handbook is one of them, and is really worthwhile. There are lots of infographics about how to reduce stress for caregivers, staying connected to others. That social interaction is really important. To seek and accept help. I've often taken family members aside and said, listen, you need someone. You need to make sure that you have someone to discuss this with, who can hear you, who can provide you support, which is always a challenge because that's more time away from what they feel that they need to do, right? And there is that challenge here, is that you have to have time. You're going to make time when you don't have any to learn. Lack of understanding of the disease process is such a big contributor. Respite care, so fundamentally important. Sometimes family caregivers will absolutely refuse respite care because it's a pride issue or they feel guilty, and working through those barriers is really important. And because people have to practice self-care in order to practice care. This does include exercise and eating better. And of course, when you're tired, your body changes. You want more fast carbs and processed foods, which increases your own inflammatory response. Sugar is the brain killer, and people get sick. Meditation and breathing practices are very important. Whatever one can do in their context, but it's important that carers are also cared for. Which then brings us to the last slide before the discussion with Claire. And again, a reminder of the Can Protect study. Right now open to all Canadians 40 and up, soon to be all Canadians 18 and up. The consents, the study information are all there on this website, canprotect.ca, can-protect.ca. We also have a help desk for people who have questions about the study. You can either email or phone. As I mentioned, there are brain gains within the study. And we are also in the process of organizing a caregiver advisory group from Can Protect participants who are caregivers to help inform us about the important needs in the field. And we either have just or will be in the next days sending out a newsletter to all Can Protect participants. Well, about almost 2,000 of them who consented to be sent the newsletter. And that will highlight some of the initial findings from the study, as well as seeking volunteers for this advisory group, again, which will help us steer this big boat to answer the right questions over the years, because my own clinical experience only goes so far, and I need to hear from you. I need to hear from carers, formal caregivers, informal caregivers, about what we need to know, what we need to do, because we can evolve this study over time. And it's not set in stone, and we can add important questionnaires or assessments. But that comes from having participants. So hopefully those of you who are watching are able to join and help share your knowledge, your expertise, your experience with clinicians and researchers like me, so that we can overall improve over time our ability to care for persons with dementia. Thank you very much.
Thank you so much for such a comprehensive presentation. I mean, wow, what a way to kick off season 4, and to really provide such a really incredible overview of all the potential factors that people are experiencing. I think that a lot of, you alluded to the fact that a lot of caregivers suffer in silence. And,
Very much
a lot
so.
of people think, I'm all alone, and, I'm the only one that's feeling guilty, or I'm the only one that's doing this, or, I would call it the not good enough syndrome, right? Like, I'm not a good enough wife, I'm not a good enough mother, daughter, son, spouse, right? And so I have a feeling that so many people who are watching this webcast are sitting there going, "Oh my God, that's me." Right? That's me. And
Oh,
but you just,
hopefully,
yeah,
yeah,
like I hope so. And I hope that, I think what you've highlighted is that these are normal symptoms of caregiving, right?
absolutely.
One aspect that I think we need to reiterate is how verbal aggression could lead, not with everybody, but it could potentially lead to physical aggression. And I work with a lot of families, and I hear from many people that, oh, it only happened once that they grabbed me. It only happened once. Can you just allude a little bit more on that point?
Absolutely. So again, with our episodic approach to aggression, yeah, it only happened once. Okay, it only happened once. But the question is, first of all, what happened only once and how severe was it, right? And sometimes our measures of agitation only assess frequency. And you can have something very severe that happened once that is a very big deal. We need to be more aware about that. In terms of the evolution of symptoms, what tends to happen is that verbal aggression can, again, it can evolve insidiously and become a change that isn't identified as a symptom or a syndrome, within the dementia process, within the disease process. And so it's a bit normalized, and okay, I know not to do this or say this because they will do that, right? And then it amplifies from there, and it's tolerated over time. And people will be snappy or snarky, or they might yell, and you know what to do not to make that happen. But this, while it may result in peace for a period of time, at some point the brain changes enough that even that's not good enough. And I've seen, many of us have some pretty graphic things, happen as a result of physical aggression. Um,
So
and
the families will be asking then, what do I do? And
right.
I've received a lot of these calls, as I work privately
Mhm.
also with a lot of families. And so, and correct me if I'm wrong, but what they need to do if they feel threatened is they need to bring hopefully with the help of other family members, is bring their loved one to the emergency room, because you can't, if it gets to a very serious situation,
Mhm.
you
That's
can't
right.
just let that go,
That's right. So it
you,
needs
you, yeah, right?
you're absolutely right. Absolutely, it needs clinical attention. Ideally, it's identified and managed long before an emergency room
Right,
visit is required. And that's why
right.
I really advocate for identification of verbal aggression, that change in style or tone,
Yeah,
because it's at that point then more systematic and rigorous non-pharmacological measures work, right?
right.
When you look at studies that say which are better, pharmacological and non-pharmacological, you can't actually compare, because when someone's really, physically aggressive and violent, you can't you can't you know give them music therapy or aromatherapy. It's too late, right?
Mhm.
You end up unfortunately giving medications, but those have a chance at working earlier on, and so studies that claim one is better than the other, they actually have to be administered in the same group to really understand that, and that's hard to do methodologically. But in
And
the
yeah,
verbal aggression group, non-pharmacological measures can work better. Montessori materials, for example, have been shown to work in people who lose their verbal skills or have impaired verbal skills, but then get frustrated with that, using their hands. So those things work better at that stage. But also, medications like, garden variety antidepressants are much more likely to have a good effect at that stage. And not because someone's depressed, but because of other effects of that medication that the people, I mentioned the filter fuse, and frustration tolerance. And I kind of use those three
mhm.
F's. And the filter is better, the fuse is shorter, and the frustration tolerance is better, often. when treated at that stage with gentler medications. But if you end up in the emergency room, and I'm loath to see my patients end up in the emergency room, they will be prescribed antipsychotics, and we don't want that unnecessarily. Now, again, I don't want to vilify these medicines either, because the only indicated medications in Canada, there is an antipsychotic. In the US, very recently, a different one. And they certainly do have a role, but we want to use them as a last resort. And we want to identify this much earlier than the time when the only option is to go to emergency, because then that's what happens.
Right. And that's why it's so important to educate, I think, the public at large, that dementia is so much more than just memory loss. People think dementia is memory loss. It isn't. And as you showed, it results in a significant change in person's behavior. And, as you mentioned as well, when a person's behavior changes, it does. And if they have dementia, it's not the person, it's the illness. And
that's right.
It's the illness. And I compare it, I hate to use this, but I compare it by like a devil sitting on a person's shoulder and saying, act this way, say this, say everything, say anything you want, right? Act before you think, right? But it's like a devil telling them what to do. And, a lot of people think, well, why bother going to see a doctor? There's no cure. But even more so, it's important to work with a doctor, because when these symptoms of depression, agitation, verbal and physical aggression begin to occur, that's where there are medications that could treat that, right? And not wait till that crisis occurs, right?
And crisis medicine is seldom good medicine when it comes to dementia, right? So we want to be forewarned and address this early on as much as possible.
And I work with a population where I would say the majority of people I work are the kids, right? So it's mom or dad. There's a mom or dad still alive, but I find oftentimes the mom or the dad aren't being honest with the kids in terms of how bad it's getting, right? There's a stigma. Yes. They don't want to tell their friends. They don't want to tell their kids how bad it is. And that becomes a problem, because they are the ones that are suffering in silence. And it always takes a crisis to occur of the healthy parent for something to change, right?
Yeah.
And it's so important to be honest and to talk about it, so that you can get the support that you need. Because unfortunately, especially if you're dependent on the public healthcare system, if you're in a crisis, you're going to have to wait months and months and months to get that help, right? So there's such a stigma.
There is, and absolutely addressing the stigma is really important, because I see this play out time and time again when one spouse is covering for the other, and because of stigma or shame or whatever, and then that spouse passes away, and then the person left behind has cognitive, functional, behavioral changes, and the kids are caught very much off guard, and they think it just happened suddenly, when in fact it may have been happening for a number of years and could have been addressed earlier, were there less stigma and more openness to talk about these things.
Well, thank you so much for taking the time to be with us today. And I really encourage our viewers to participate in your Can Protect project. We will also put a link under the trusted resources of our website at mcgill.ca/dementia. And as you mentioned again as well, nothing replaces education. The more educated you are on this disease, the more educated you are on the resources that could support you, the more ahead you are with regards to all the legal and financial aspects. But it's really, being one step ahead of the illness at all times and becoming as educated as possible. So thank you so much for taking the time to be with us today.
My absolute pleasure, Claire. Thank you very much for having me. I really appreciate it.
So this webcast is an initiative of the McGill University Dementia Education Program, which is funded by private donations. If you would like to make a contribution to our program, or for more information, please visit us at mcgill.ca/dementia. And if you would like to join our mailing list to be notified about upcoming episodes of McGill Cares, as well as other important programs and resources from us, you can email us at dementia@mcgill.ca. Thank you for watching.